All right, Miigwech, merci beaucoup. Thank you for joining us this evening for our Health Sciences webinar entitled Out of the Comfort Zone, Giving the Traditional Student Placement a Virtual Makeover. This webinar is going to be delivered by Kathleen McQueen and Colin Chan, both of whom are with CBI Health Group. I'm Dr. Michael Ravenick, the manager of the Health Sciences programs at NOSM. And before we get started, I'm just going to do some quick welcomes and introductions. And of course, this is our usual agenda for the webinar starting at 6. And after those welcomes and introductions, getting into the webinar for about 40 minutes or so. And we'll have a formal moderated Q&A period. And so certainly, if you have any questions that come up during the webinar, please do put those into the chat box. And our moderator, Haley Mazziero, will make sure that those questions are brought to the speaker's attention to address during that moderated Q&A period. Okay. So just a reminder, this webinar is being recorded and will be posted to YouTube within 2 to 3 weeks after the webinar. Our first 3 webinars are now all on YouTube, and you can find the links to those webinars on both the Rehabilitation Science and the NODIP websites. So we'll start with our land acknowledgement. So we acknowledge that the entirety of NOSM's wider campus of Northern Ontario is the ancestral traditional lands of the First Nations people and Métis people who resided alongside. We also respectfully acknowledge that the medical school building at Laurentian University is located in the Robinson-Huron Treaty Territory and at Lakehead University in the Robinson Superior Treaty Territory. So one of the new developments that I'm excited to let you know about tonight is that in the very near future, we're going to be launching the Preceptor Development Series for Health Sciences Clinicians, which is actually going to replace the Preceptor 101 sessions that used to be offered. And these will be offered online, both synchronously in small groups as well as asynchronously, and are also going to be offered in person once we're able to do so again. So keep an eye on your inbox for a formal announcement and sign-up information. That email will be coming at the beginning of December, and the first sessions will actually take place in January. And there's going to be 12 different sessions, a different topic each month, on topics related to clinical education and preceptorship. And if you haven't done so already, please do sign up for our mailing list. You can email hsplacements@nosm.ca if you're not quite sure if you're on the list yet, and we can check for you, and we'll also make sure that you get signed up for the right list, whether that is for rehab science, for NODIP, or the physician assistant program. So I'll introduce our speakers. Our first speaker is Kathleen McQueen, originally from Sault Ste. Marie. Kathleen is the Manager of Clinical Services Design for CBI Health Group. She has a master's degree in science and occupational therapy and has worked in the home and community healthcare sector for 15 years. She passionately believes in the future of healthcare at home and is committed to driving the adoption of innovations that deliver better care and positive outcomes in the home and community. In addition to designing new and operationally sound interdisciplinary clinical models, Kathleen works closely and collaboratively with many teams across Home Health Ontario and CBI Health, bringing her energy, innovative approach, creativity, and vision to move CBI Health forward into the new reality. Her ongoing partnerships with academic institutes and participation in research demonstrate her commitment to evidence-based practice and showcases CBI Health as a forward-thinking and a solutions-focused partner. Our second speaker is Colin Chan. Colin is an occupational therapist with CBI Health Group. He graduated from Queen's University with a master's in occupational therapy in 2006. And his work started in the clinic working within multidisciplinary teams, but in more recent years in the community, working closely with clients in their homes, in their communities, and their workplaces. Colin currently acts as the provincial manager in the Psychological Trauma Community Rehabilitation Program at CBI Health Group, where he leads a team of OTs across the province in delivering the highest quality care to individuals who have experienced trauma, helping them to build resilience, to achieve post-traumatic growth, and to ultimately continue to live life following trauma. Colin believes that there is hope for all individuals, and that with the right care and treatment from the right clinician, people can do better than just cope with their symptoms. Rather, individuals can actually be better and move forward from their trauma once and for all. Miigwech, merci beaucoup. Thank you both Kathleen and Colin for your time today. It's a very exciting topic and one that's very in line with the times that we're in. So now I'm going to turn things over to you and allow you to share your screen.
Thanks, Mike. Hi, everyone. We are so happy to be here tonight to be able to speak to you a little bit more about our experience offering a virtual placement. I'm just going to take a minute here to share my screen with you, so wish me luck.
Thank you, Mike, for the introduction. And hey, Kathleen.
Hey, Colin, how's it going?
Good. And thank you, everybody, for joining. It looks like we got 27 folks online at 6 p.m. on a Wednesday night, so appreciate your time.
Can you guys let me know if you see my screen? It's connected right now.
Not yet, Kathleen.
Oh, okay, 1 second. It's just loading. Bear with me.
So maybe just while it's loading, I don't know what the easiest way is. Maybe Mike, you kind of get a sense of the room, but just so we understand the audience. So School of SLP, like what kinds of faculties are we talking about here that's in the room?
Yeah, well, we are the health sciences programs at NOSM, so representing all of the rehab professions, OT, PT, SLP, audiology, as well as the NOTIP program, Northern Ontario Dietetics Internship Program. The health sciences also includes a physician assistant program as well, and medical physics. So it's quite a broad health sciences audience.
Okay, perfect. All of whom I assume have been affected by COVID and the availability of placements and fieldwork opportunities. So hopefully we can shed some light on what we've done that will help out.
And I don't think you guys are seeing my screen still.
I can see.
No.
Yeah,
we can see your screen, but it's your email right now. So we were able to see the PowerPoint a moment ago. I think you just needed to put it into presentation view.
Okay, let me try and let me know if it comes up.
Yep.
Yeah, it's right there. So I think you just have to start the presentation.
Okay, sorry you guys. Every day it's a new challenge with virtual care for me, so I appreciate your patience. So the title of our lecture today is Out of the Comfort Zone, Giving the Traditional Student Placement a Virtual Makeover. And we already went through introductions, so I will move ahead. A bit of an agenda for today, and please stop me throughout the presentation if you have any questions, any comments. Colin and I are more than happy to answer questions and chat with you throughout the presentation. Brief agenda is introductions, a bit of a background, go into a bit of detail on my northern roots. Then we'll go into the first ever, that's what we're calling it, virtual OT placement, leading off into the second ever virtual OT placement that Colin was the lead for. So just want to give you a little bit of background about CBI Health Group. So CBI Health Group is a community-based integrated healthcare provider. We were founded as a research and education-based organization. CBI opened its first site in 1975 and grew through the years. We are currently helping more than 300,000 people within 800 communities across Canada.
So I'm from the Sioux. I have northern roots. You would know it as Sault Ste. Marie. We call it the Sioux. I'm hoping that some of you on the line and on the call would recognize that and see some familiarity with some of these slides. So my point to this was you know, Sault Ste. Marie, there's a few pictures there that really resonate for me of what it means from coming from a northern community. You can see there's the famous Wawa Canadian goose. There's, of course, the Sudbury nickel, which, you know, as children, we all took trips up to see. This was sort of like one of the vacations that we would do. And I think, Colin, if you just click the next slide there's, of course, Science North. So this is just my way to introducing this group to the fact that I am from the North. I'm very familiar with some of these really recognizable landmarks in Sudbury, and it was a big part of my childhood growing up, and really makes me part of, you know, who I am today. So that's this next slide. What does all of that have to do with delivering virtual care and offering student placements? You know, in my opinion, and you can go to the next slide. Thanks, Colin. I think it has a lot to do with it. So, you know, being from a northern community, and I think probably most of you would relate to this, life is just a little bit different. I think, you know, we have to be a little bit more creative, a little more innovative, a little bit more resilient, and a little bit more agile to make things happen. And I think that's probably our experience growing up, and our experience, you know, even relocating to a northern community. There's a lot of different challenges that we face. Some of that has to do with the weather. Some of that has to do with a lack of resources. Some of that has to do with the professional networks that we have up in northern communities. But all that to say, I think there's a lot about coming from these communities and more rural areas that makes us a little bit special, a little bit well prepared to innovate. And I think it, you know, prepared me for this opportunity really, really well to offer this virtual student placement. So, you know, the key takeaway message from here is, you know, stop thinking in a straight line, essentially. So another key message, I think, which particularly resonates for me from being from a northern community, is this idea of collaboration. And I think this is essential and foundational, you know, not only as a student growing up from a northern community, but probably as a professional practicing in a northern town or city. And that has really extended into to my work life now. I think, you know, great things can happen if we collaborate, if we develop relationships, if we foster those networks, if we really rely on others to help us drive our work forward when we need a little bit of boost or a little bit of motivation or a step up. And one of the things I wanted to pause here to talk about was my collaboration with Dr. Ravnik in the past. So this was not sort of my first go at offering a virtual an innovative student placement. Mike and I had worked closely together here in London, Ontario at Western University to offer an interdisciplinary placement that was set to roll out just as the pandemic was sort of becoming problematic this summer. So the idea behind that placement was to offer a placement in retirement homes with OTs, PTs, and SLPs together, forming small, little specialized teams going into retirement homes and assessing residents for areas where we could really target health promotion, disease prevention. So we were really looking forward to that and had done a lot of work on that. And then we had also implemented another type of student placement, which was just strictly a project-based placement, where we took occupational therapy students and really worked closely with them over 8-week periods of time to drive some of our project work forward. So program design, program implementation, evaluation. So we had sort of had, little baby steps along the way to this virtual placement that had really led up to my confidence, anyways, in my experience, to be able to put this idea out there. Okay, next slide. So trying to move quickly because I've wasted a bit of your time here, but So this was the impetus behind the virtual placement that we offered. So, the pandemic hit, and Colin probably touched on this, and it really changed life as we knew it. So a lot of disruption to how we were all living our daily lives, a lot of disruption to how our clients and families and communities were functioning. People were not receiving the healthcare services that they had received for years in their homes because services were put on hold to try to prioritize hospital transitions. Clients and families weren't accepting healthcare providers into their homes and communities just for fear of having, new individuals into their homes. And further to that, even our providers were scared. Parents with children not really, knowing what to expect with COVID-19 and going into different environments. So this, really led to a lot of disruption and a lot of fear and just a lot of changes for our company, and I'm sure companies, absolutely everywhere. At the same time, we were receiving a lot of this messaging from the student faculties, letting us know that student placements would go on hold indefinitely. I got some messaging from the occupational therapy faculty, letting me know that, most likely the OTs weren't going to graduate this year. And so I just remember thinking in my role, there's got to be something that we can do about this. We're experiencing this shortage of human health resources that we're seeing in the homes and communities. And then we have this group of, students that are, on the doorstep of graduating and entering practice. And, is there not something that we can do to bring their skills, their talents, their expertise, out into the community and really make this work for everybody? So that was really the initial thought behind it all. And after having that thought, there was really no stopping the idea because, once I had that thought, I brought it to our senior leadership, which was sort of a modified pitch to say, what do you think about this? We're experiencing all these challenges that I mentioned. There's this talented group of OT students that I would love to be able to help. It feels like, we could certainly do something with that. And our vice president of operations is an occupational therapist, and Colin's an occupational therapist. So we have a really rich background in OT, PT, SLP, dietitians, social work, and a variety of other disciplines that work within our company. So immediately there was a lot of interest, in what we could do. So after that, I reached out to the university, and once I did that, the ball was not going to stop rolling either. So once again, this was that network piece, that collaboration piece, where I had pretty good relationships with people there, had quite a bit of trust, and we just started talking and figuring out and collaborating and co-designing, what could be possible. So this was really, an amazing experience for me because, when we brought all those minds together that had a bit of trust in each other, a bit of familiarity, the art of the possible became possible really quickly. So some of the key things we had to keep in mind when we were designing this placement was safety first. And that's really why we went with a virtual piece versus a hybrid model like Colin's, because at that time we really did not know what was going to be happening with sending students out. We wanted to offer a consistent and standardized experience for students. So the best way that we could do that was really by offering a virtual only placement so that we could guarantee that we could take the entire class. So that was 56 students at the time. We wanted to be able to say, we can offer this to absolutely everybody, a standardized experience. We'll do our best. And so that's how we moved forward. We also had the guiding principles of optimizing students, optimizing clinicians, optimizing our technology. So, that was incredibly important for us to think, how can we use technology to really deliver a different experience, but also to drive our work forward and really ensure that students have a unique but quality experience on placement. We also had to think about return on investment, which, was a new piece for us, but with the technology, there was so many new learnings for us, and we had to really mobilize our entire IT team for probably about 2 to 3 weeks to get all of the students on board, to get them access to their own accounts, to get them within our secure environments. And so we had to think, we're already short for our support teams, what is this going to do if we absolutely monopolize their time for 2 to 3 weeks? We had to quickly identify and recruit champions and preceptors, and this was much easier than I thought it was going to be. Colin was actually one of the preceptors that volunteered quite quickly from our rehab division, and we brought on quite a few from our home health division too. And I think, at that point when Colin and a few others from our rehab team volunteered, we really knew that this was going to be also, I think, such a special experience for our organization to collaborate across our different segments, because we don't get a lot of opportunity to do that. And it was really clear that everybody was very motivated to get the students graduated and to come together to find a way. Just 2 other quick points on this slide. This was critical in terms of implementing this virtual student placement. There was a lot of planning, and a lot of adapting, and then adapting and planning, and then launching the placement. So we had to have backup plans and then backup plans for those backup plans. And we had to get it approved from multiple levels of stakeholders. We had to sort of guarantee to Western University that, that we had this, but if something fell through, there was going to be a backup plan and we were going to be able to come through. And then another key piece was, very early on, we committed to constant evaluation. And the evaluation allowed us to continue to evolve during the placement. And then, there was more evaluation, and we'll talk a little bit more about that in just a few slides.
And just one thing I'll add, Kathleen, is that, if you guys are all making the pitch to different employers or different organizations to take placements, virtual placements, as we're now, 8 months in or so into the pandemic, I think people, COVID fatigue has definitely started to sink in as we start to look at the next, 7-8 months, right? But the daily grind of doing clinical work and seeing clients, that is stressful for sure. But I think what we've seen is that there are some clinicians out there that just want something different, to change it up day to day and to do something more meaningful, and to give back to students and to teach, I think, is a nice break. If the organizations allow for it and there's support from leadership, I do think it's a really rewarding kind of project for them to take on a different kind of placement opportunity.
Yeah, absolutely. So sharing out this slide, I won't go into a lot of detail, but when I did do the pitch, I wrote a really formalized proposal with a lot of words, a lot of research, a lot of citations to back up sort of the evidence behind this type of virtual placement or a clinical rotation placement. And this is kind of what we settled on. So my key point to this slide was, it didn't in the end have to be super detailed. It had to make sense. We had to provide sort of a visual and connect the dots for those stakeholders involved. But once we were able to do that, we were moving forward. And so the way that I had envisioned the first round of placements to take place was that we would use part of that placement experience that Mike and I had developed, the project-based placement, and really make that a foundational piece of this placement. But we were going to take it to the next level. So we were going to use, all of those segments that I tried to introduce early on in the slide. So our rehab segment, some of our community mental health, our school health, our home health segments, to be able to offer these very unique projects, these independent projects to students. And then what we ended up doing, because there was such interest across the organization, was extending that to our communications team, our IT team, our social media team, you name it. We had over 150 projects that came in that were submitted to the placement before the students even got started. And when I looked at the variation of projects across our organization, it was really clear that everybody, had projects that they wanted to work on. Everybody sort of does that work off the side of their desk, but if given sort of this boost of human resources and the student expertise and energy, they were all sort of willing to jump in and put their projects forward. So that was so exciting. The second piece was the virtual care piece. So we knew we were very much struggling with our home health teams in terms of adopting virtual care. And we knew that the students were going to struggle a little bit. This wasn't part of their curriculum. This wasn't part of the way that they envisioned that care would be delivered. So what we did was we developed a bit of a system that worked really well. And this goes back to that piece about really looking to optimize, you know, both the students and the clinicians during this placement. So we had the students come in and do some training with our solutions team. And then we had the students for the first week or two turn around and offer one-to-one sessions with our clinicians. Because our clinicians didn't want to have training sessions with us. They didn't want to have training sessions with the solutions team. They were so open to training with students, having that personalized touch. I think, you know, there's a piece about sort of student preceptor, the cross-generational learning that was really key with this. But the students came out, and this way they were able to learn about virtual care, the ins and outs, and then they were able to teach our clinicians, which furthered the adoption of virtual care. And then they were learning, you know, what it takes to train clinicians, which is not the easiest thing in the world to do, to facilitate that change management and to develop resources that you know, really promote their uptake of this. So that was really, really a neat piece of it. And then the other two sort of clinical rotations that we had within our first placement was offering some enhanced programming. And we really developed these programs so that we could facilitate the students having some independence with clients and families. So we developed a social isolation program where they would be doing check-ins, particularly during COVID-19 with clients and caregivers who were not receiving regular care or regular check-ins. And then we developed sort of a 2.0 version of our Care for the Caregiver program where students could have more independence, you know, virtually delivering services to caregivers, connecting them to community resources. Okay, next slide. Thanks, Colin. So what did this placement end up looking like? And I'm going to try to pick up my talking points here. We had 9 preceptors in total, as I mentioned, across the CBI Health segment. So imagine for students when we sort of first said to them, surprise, you actually are going to go on placement, all of you, to the same organization, and you're all going to graduate. You know, there was a lot of relief, but there was also a lot of anxiety around how does an organization offer 56 placements? How can this be a quality experience? And I don't want to have, you know, a placement in home health, maybe I just had one of those, or, you know, I had my heart set on this mental health placement. So the really cool thing about us as an organization was the students could choose from, you know, a number of different practice settings. So if they were due to have their next mental health placement, we could facilitate that for them. Or if they were, you know, really looking to have that school health placement, we could do that as well. So that was a relief to the students. The CBI champion pieces, so there was the preceptors, of course, who were the ultimate champions, but then there was this interdisciplinary network that I was so proud of in our organization that steps forward either to submit projects, to lead projects, to take students on their virtual visits. So, you know, that involved PTs, SLPs, nurses, PSWs, managers, directors, all the way up to VPs. The enhanced programming piece that I just spoke about, so, you know, really designing and implementing new programming. And what was really neat about that was that it would have been impossible if we didn't have the students in place, because we made those projects. We actually made running the whole program actual projects. So we had the really keen students take leads of those programs, manage referrals, manage doing the evaluation piece. So it was really neat to see how that kind of evolved. As I mentioned, we had these 150 projects, which, you know, I think sort of led into a big component of Colin's placement. You know, as I said, just really sort of surprising how much work there is that people want to get done. There was the clinical rotations, as I mentioned. And then another key piece that I haven't talked about was these guest speakers. So we were able to invite experts, guest lecturers, clinicians that would offer day-in-the-life experiences to our students. So each week we would have a new lecture. It was optional for the students to attend, but we brought in some really neat speakers from across Canada, really, to speak to the students and give them different perspectives, either, you know, on their discipline or their area of practice. Students had to be very self-directed. So, you know, there was the project piece, but there was also sort of this project management piece, program management piece where they were running programs. We had set up an MS Teams channel just for them where they could offer each other peer support. They were able to talk to each other through difficult situations, offer IT support to one another, which was really critical. And they self-organized Pizza and Perspective session weekly, where they could just get together and sort of share how they were feeling, how they were doing. I don't know if Colin touched on it, but we did modify our evaluations so that students would complete a large portion of it, and the preceptors would really just sort of verify and check off the evaluation. One of the key lessons that I'll talk about in the next slide is that in terms of the existing evaluations that we use in competencies, there's probably a bit of a need, in the future, given the fact that virtual care is here to stay to adapt that. And then once again, data collection and evaluation. This part sort of got me in trouble at one point where I thought, I just can't keep up with the data collection and evaluation. We were surveying the students every week for their feedback. We were surveying the clinicians and the preceptors. But in the end, it was all worth it because we have all of these great insights and learnings from the placement. So lessons learned, and Colin, just jump in because I know you have a slide that talks a little bit about this. So, what did we do well? Really, we collaborated well. We remained flexible. We adjusted when we needed to. We all came together, I think, for a united purpose of helping, this class graduate, and that was really motivating. It gave us all something to look forward to, something that was positive, in a world that was seeming really negative. And we flexed when we needed to. If something wasn't working, we changed course. We all stayed really transparent. Each week when I had the survey results, and the feedback wasn't always perfect, it wasn't always rosy, I would share that feedback out with Western University, even though sometimes that was difficult to do, but the transparency was so key. And I would share that out with our senior leadership as well. And that just made everything, as I said, really transparent and built trust, and really led to us just all problem solving together. What we could improve, we could certainly improve if we had more time. Certainly improve probably preceptor numbers, the ratio students to preceptors. We could probably improve our evaluation methods a little bit. We could probably have, customized the experience for students in a bit more detail and thoughtfulness to ensure that they were getting the learning experience that they wanted. Mistakes to avoid and problems we could have avoided. I think IT, can you guys still hear me?
Mm-hmm.
Oh, okay. I just saw a chat, someone in the chat who couldn't hear. For me, and Colin probably has different ones, IT was a challenge. It was just a huge undertaking for our team at that time. And so some frustrations from students around the onboarding process. That would be something that, we would try to plan out a little bit more. And then connecting the dots with the competencies. As I said, I think we probably need to look at, as virtual care is more embedded in what we do, what competencies look like for each of our professions, and how you can still achieve those competencies in a virtual care world.
Yeah, I'll add to that. I think that the feedback that we received consistently was that students were very appreciative, given the fact that the people that did not get that opportunity ended up not being able to graduate on time because they weren't able to fulfill their hours on placement. So I think people recognized that this was a unique and kind of unprecedented thing, and everyone had to adapt. And I think the students that got the most out of this kind of placement were the ones that realized that they got what they put in, right? So I think they did appreciate the flexibility and the ability to adapt and to offer this kind of unique placement. But definitely, Kathleen was a lot more organized than I was, and she did a lot of planning in advance. When we got to the rehab side, I think for me, it was a lot of building the plane as we were flying it. So I think in terms of improvement, probably now that we have this experience under our belt, I think just being a little bit more, at least on my end, kind of thoughtful about how we deliver it, given that it is a tough situation. And Kathleen mentioned the projects, and there were 150 projects. All of them were great, and we wanted to provide some choice, right? So not everyone got the placement that they wanted, but if they didn't get the setting that they wanted, then maybe we could offer them a project that was in line with what their interests were. So we did the best we could to assign projects and placement opportunities with people's interests and goals, but given the numbers, it's not always possible. And let's just move down a little bit further, just recognizing time. So maybe we skip forward a little bit, Kathleen, unless you had some key points here that you wanted to talk about.
No, we can loop back around this slide at the very end.
Okay. So we took on a large cohort of students across different schools from the months of May until the end of August. And to be quite honest, in the initial phases, we thought that at least I did personally, bit off more than we could chew. At the time, COVID was stressful and taxing on everybody. And a lot of our clinicians were not capable or, nor did they have the bandwidth to take students, from a time standpoint and energy, but also from, being in private practice, just the pressures of the business and the stress that came with that. I think not many people were in a position to take students. So we had some of our staff and our clinicians step up and volunteer, but not as many as we would have usually seen. So myself and Kathleen took on a larger role and took a lot of that onto our shoulders. But we had to come up with a creative way to deliver a meaningful learning experience to the students that was obviously going to be different than the traditional. Now, Western was one of the first to innovate and to be on board with it. And because they were the first, and at that time there was so much uncertainty around restrictions and what have you, that it was determined to be 100% virtual. So those students were not able to see anybody in person. As we started to flow into the summer months, and as other schools and ourselves at CBI got a bit more comfortable with what was allowable and what was safe and what met public health guidelines, we were in college recommendations. We were able to do a bit of a hybrid model that our students were able to do virtual, but then also mix that in with some in-person visits as well. Recognizing that was difficult because the ratio of student to preceptor was about 15 to 1, if not more. So one of the things that we came up with was that at CBI, large company, variety of settings and contexts, we could provide within one official placement the opportunity to see a variety of clinical settings. So to almost provide multiple placements and fieldwork opportunities within this one setting. And it was a matter of connecting the students with a variety of subject matter experts across different streams. So here we delivered some workshops. For me specifically, we focused on psychological trauma. We talked about work in the auto sector, in the disability sector, traumatic brain injuries and concussions, a lot of mental health topics. But we really tried to tailor it to what the interests and the needs were of our students. And we put it out there to see kind of what they were interested in learning. And some of the topics were about just practice and, how do you build a caseload and how do you market yourself as a clinician, maintain a caseload, those kinds of things. So these were delivered across the 8-week placements. They were all on, so the platform that we typically use within CBI is Microsoft Teams. That's the platform that we use that's been to be secure and safe and confidential. It meets the standards of all of our funders and contracts across healthcare delivery within Canada. And we also use Zoom as well for some of those workshops. So it was a nice way for us to, again, deliver content that was more didactic, at least, to the students. But recognizing that learning-based format is not exactly a placement experience, we needed to be a little bit more interactive. So what we did was we followed up with those lectures with opportunities to integrate into practice. Just tricky when you have 100 people on a Zoom call. But what we did was we broke down specific scenarios that were teased out of the workshops, specific parts of an assessment or specific elements of treatment. And then we basically asked everyone to turn off their cameras and 5 people at a time turn on their cameras, right? And then I I go through the scenario, I act as the mock patient, and each of those students kind of takes turns taking a stab at a piece of that intervention or providing the education or parts of that assessment. We go through a certain piece, facilitate some conversation, some discussion, people can ask questions, and then we cycle through. So those 5 people turn off their cameras, the next 5 come on, do the same thing. So it gives everyone an opportunity to at least be a little bit hands-on. Everyone gets to see what other people are doing, see their mistakes, see the things that they do well. And then it's all guided by some conversation, facilitated discussion around things that they may have missed or things that they should look for in each of those specific sections. We went through hard skills, clinical skills, specific, pieces of psychoeducation. Role play is really important, I find, and I think that for students that learn things from textbooks and learn things in labs and in classrooms, when it comes down to seeing your first patient and you've never delivered that education before, or if you've never used that analogy before, it becomes tricky. Things that you felt pretty confident in knowing conceptually, you start to fumble. So it was important for us to give people the opportunity to practice some of those skills. So we did that not as often as I would have liked, but we did that over the course of the 8-week placement as well. And then we also had, so it was of value for the students to participate and to share and to learn from each other's mistakes, but it was also important for me to provide opportunities for the students to see what a skilled clinician would do, like how they would say things. So we had 2 OTs kind of go through different scenarios, and they recorded them in advance, and we basically played them to the students in a group setting. And we broke those down, and we allowed for some discussion afterwards as well. So again, some simulated scenarios and some observation. So again, this is all what I would consider to be kind of that classroom piece. And then we wanted to really facilitate the actual client interactions, face-to-face, but virtual. And this is where it got tricky in terms of consent. But just to give you an example, I would do a home assessment. So say a client was involved in a car accident, is discharged home from hospital, struggling physically. There's some mobility issues, physical impairments, struggling with their activities of daily living in the home. And the OT's job is to go in to do an assessment, ask questions, gather information, and to come up with and do a physical and functional exam as well, and to do an environmental scan, and to determine what recommendations as far as equipment or PSW supports might be necessary, home modifications to facilitate that client's independence and safety in the home. So what we would do is, with client consent, obviously, I would go into the home. Again, this was during COVID, so masks on, full PPE, etc. A full screening process. And if the client was screened negative and risk was determined to be low, I would go into the home. But we had agreed prior that the students would facilitate the assessment. So I would get the paperwork signed and get the consent, all that stuff out of the way. And then I'd have my tablet or my phone, and I put it on the kitchen table and have the students, sometimes as large as groups of 10 students, take turns doing pieces of the assessment. So one person would do the consent piece, one person would do the information gathering, one person would guide the physical assessment. So they would each take turns, and they would all prepare in advance about who would take which part. And then they would conduct the assessment with me physically being there to ensure safety from the client. Not everybody would agree to this, obviously. This was a bit of a tricky situation and not the ideal way, but again, it was better than me doing the assessment in person and just having them observe. This was our way of having them interact and to participate. Intervention was similar. So a lot of our interventions involve mental health. So we do a lot of education, a lot of psychoeducation, education and practice of coping skills, planning for activation, setting goals, getting people to do more meaningful activities, etc., and a lot of exposure therapy that's specific to trauma, which is very tricky to do at the best of times when it comes to clients who are avoidant and have anxiety and extreme PTSD symptoms. So we had to be selective in terms of our clients who would participate in this, who would be willing to have their sessions led by a student, not only a student who they did not know or trust or feel safe around, but a student done virtually. So again, OT and client are together in person and then you have your student over a tablet, over a phone, over a safe platform, Microsoft Teams, deliver that education. And that session was guided by and led by the student. So challenges, as you can tell from the first 20 minutes of this presentation, internet connection is always a bit of a crapshoot. You never know on any given day what can happen, so you have to be able to kind of roll with it. When you're using, internet connections within clients' homes or in the community, that becomes even more dicey, right? You're relying on your clients or your patients' devices or their Wi-Fi. Depending on the rural nature or the locations of your clients, that can be a bit tricky. And sometimes we had to use just straight up telephone with no video. We'll talk a little bit about the ability to build a rapport over Zoom or over a video call when you don't have that direct personal connection, staring each other kind of eye to eye. It's a little bit different, both for client and both for clinician. But what we have seen based on our surveys is that with some practice, it's possible, and our outcomes are quite strong in terms of satisfaction, in terms of clinical outcomes, effectiveness of treatment, return to work. All of those outcomes that we measure ourselves by did not slip with changing to more of a virtual platform. So it is possible. I think a lot of people don't think it's possible, particularly when it comes to like MSK, physical-based injuries. But this is the new way, and I think if people buy into it, it does work. Anything you want to add to that, Kathleen?
No, I think you captured it. Yeah, no, that was good, Colin.
Okay. Lessons learned. I mean, again, we did what we could at the time with what we had, but, for example, Queens, I had 30 students assigned to me personally. So in terms of fieldwork evaluations at midterm and at the end, simply not having the time to be able to customize my feedback and my evaluation to each individual student, did the best we could based on the opportunities I had to observe them, right? And not everyone had the same amount of opportunities, although we tried. So I think a smaller number per preceptor, meaning taking less students and hopefully getting more volunteer preceptors would be helpful. And Kathleen talked about maybe adapting the fieldwork evaluation process because those forms can be quite rigid, as any student will tell you.
Yeah, and just to add to that, I had a few other points added to this slide, so apologies, I'll just speak to them. So, we touched on it, the lessons learned plan, but be flexible. That was just a key one. Have a backup plan and a backup plan. Build virtual care into the curriculum, as Colin just mentioned. Set realistic expectations for students and preceptors. Just keep talking about these expectations and what's happening on a weekly basis. The students were the best sort of neutralizers for this within the group, really sort of setting the stage, as Colin said, to let the others know, if you're not having a great experience, you need to lean in more, you need to communicate more. Normalize virtual care as just care. It's here to stay, and it's a tool in our toolbox. Lessons learned, again, taking students can facilitate a huge culture change within any organization. And, I think it's worth being prepared for that culture change, also leaning into that, optimizing it, thinking of where you can go when you have this, boost of energy and all hands on deck. Virtual care can facilitate engagement for clients and communities. So, really thinking about how virtual care can connect us as teams, connect us as professionals, really have clients and families, really be in tune to their own health. And it's an opportunity for new service delivery models or education models. Virtual care breaks down barriers. And my last lesson on that slide was virtual care is here to stay.
Yeah, and I think the next few slides are going to be on virtual. And the one thing I'll say about the projects too were that they were fantastic. I mean, these are things that a lot of managers and directors and clinicians probably had on their plates for a long time or on their list of things to do, but just never had time to get to. And to have these students come in and just do a fantastic job. The quality of the projects that we got in return from media to just the video and the creativity and just the presentation of it has been fantastic and has really helped the clinicians to do their jobs better and to improve their work with their clients moving forward. So it's been a fantastic experience.
And just to pause there for one quick second, it taught, and this could happen for any group of clinicians. I think it taught our organization about, what students can do. And just using OT as an example, it doesn't have to just be related to, clinical experience. An OT or a PT or an SLP or, a physician's assistant can make like a really great communications team member, or can really, bring something of value to those teams. And so through these projects, that was just, so interesting to see, and to see the clinicians or the students be able to shine where they wanted to.
Mm-hmm. Mike, I'm just mindful of the time. I know we were only supposed to speak until 6:45. It's now 7. Do you want us to kind of wrap up the last piece and then leave some time open for questions, or how do you want to play the last 30 minutes?
Yeah, no, that'd be great if you could wrap up in the next few minutes. Maybe go to your final slides, and then we'll take some questions.
Okay. For telehealth, we've touched on it throughout. There's a few points on the slide that I won't go through each of them, but really I think the takeaway is that, to Kathleen's point, telehealth is here to stay. And if you look at the research that's come out, and there's been a lot more recently, just due to the pandemic, and even internally for us, just looking at our outcomes and looking at our surveys for clinical outcomes, satisfaction surveys, those kinds of things, the hybrid model, and the opportunity and the ability to use virtual care has really honestly enhanced our service delivery. A lot of the barriers that we saw in the past around accountability and transit and scheduling, a lot of those things kind of go away when you don't have to have people drive 30 minutes and back to come. Whether it's childcare or having to go to work or having to go to school, people are able to attend their therapy appointments seamlessly in ways that work for them, without really compromising the quality of the care that they're getting. So long story short, I think takeaway is that telehealth is extremely effective, and a lot of the myths that people have, or the misconceptions that people have around wanting to do it, or the effectiveness of it are quite frankly being broken down the more people are getting the opportunity to actually try it. Which is this slide. They can't be the same quality as in person. That's just simply not true. We've seen great success, both just straight up over telephone, but primarily over video. It's only for the tech savvy. I think the one thing that we know now is that the use of devices, or the prevalence of devices in homes across generations, is higher now than it's ever been. And you think about, yes, there's going to be some grandparents and some people that certain demographics that won't have access to it, but it's much more widely available than it ever used to be. People are accessing podcasts and YouTube and different things that you'd be surprised how quickly it is, and the more apps that come out and the more platforms come out for this, you'll find that the more user-friendly they are, and the simplicity of the functionality is quite, the utility is quite high. And it's not only for those in rural or remote areas. Yes, there is a use, an application for that in those settings, but we're seeing clients who live across the street, or that live in urban cities, that again find value in the telehealth piece. So again, this is here to stay. And it's not as scary or as once what people once thought it was. Kathleen, anything else to add to that?
No, I think that's great, Colin.
Okay. And I won't speak too much about this one, but again, we're just tapping into what the future holds in terms of wearables and different adjuncts with respect to how to monitor people's activity, their heart rate, their vitals. There's all sorts of technology that's coming out, that's already out now, that's only evolving further, that will further enhance the experience of telehealth or virtual care. All right, I will end my sharing because I can't see anybody. And we'll open it up to some questions.
All right, great. Thank you both, Kathleen and Colin. After that initial hiccup, we were able to get back on track and prove that we are adaptable and we need to be adaptable with the anything virtual these days. So thank you again. And I'll turn things over to Haley because I think she's been keeping track of our questions. I know there's a bunch that have come into the chat kind of for everyone, but she might have received some personally as well. So Haley, can you summarize some questions for us?
Of course. Hi, Kathleen and Colin. Thank you for the presentation. Our first question was, how were the clients' experiences with doing virtual care with the students?
Do you want me to jump in first, Colin? So, it really varies. But what I think we tend to find is that, clients and families are really heartwarmed by students. And, if you put a student into the mix, they tend to be so much more understanding. They want to help the student learn. They want to talk to the student about their experiences. And so it's, I always find it such a special experience, seeing those generations almost be able to help each other. So I think we had a very similar thing with virtual care. And for us in home health, people were even more willing to try out virtual care when a student was involved. So that was, a really great thing for our clinicians. It was like opening a door for us to be able to continue to try out virtual care. And in particular with our students, like our school health students, it's such a good fit. The parents are so used to using virtual care to support their children that was an easy transition. And our clinicians and students found such ways to engage with our little ones virtually. They were designing games, they were designing interactive PDFs, they went and bought equipment. The way that team came together to make that a special experience for the kids was truly amazing.
Thank you, Kathleen. The next question, what did CBI do to support the preceptors in teaching and evaluating that volume of students?
Colin, do you want to take that one?
Yeah, sure. Sorry, I realized I was on mute. Just to add on to the last question or the last response from Kathleen, I think the one thing that we saw in terms of client experience was that depending on the service stream and depending on the funding model, oftentimes historically the OTs or the clinicians themselves may have had limited time to provide kind of direct supports to their clients, but because the students had more time, they were actually able to invest a lot more of their energy into spending that with their clients. So I think in those cases, the client experience and their families was very positive because they got that extra handholding that they would have not otherwise received in the traditional sense, which is nice. So the second question in terms of how the programs assisted with the evaluation process. Sorry, was that the question?
Sorry, I was muted. What did CBI do to support the preceptors in teaching and evaluating that volume of students?
What did CBI do? Okay. I think they were initially, to Kathleen's point earlier, that they were a little bit hesitant, right? Just given the nature of the pandemic and the uncertainty around it, that it affected our business significantly across the country. So to devote our time and energy into something that was not necessarily revenue generating, if you think of it that way, was a concern. But after, Kathleen was a huge advocate, after kind of talking it through and realizing that there is, giving back to the schools and to the the young minds of the future, I think was really important to us as an organization. And if we could somehow integrate the student placement and the experience into our day-to-day practices, so that it didn't negatively impact or compromise the work that we did from a business standpoint, I guess you could say, then they started to buy into it. And honestly, like working with students and kind of getting a window into who the bright students are, to be honest, coming out of school, who's going to be a good fit for this kind of work. I think it helps us from a recruiting standpoint as well. So CBI was definitely supportive. But at the same time, we're not going to force anyone to take students if they're not comfortable doing so. So it took support and the vision of leadership to say yes to this, but it also took the frontline clinicians to be able to take it on.
Yeah, and just to add to that, I think CBI let Colin and myself for the full probably 3 months be very dedicated to this work. For me, anyways, I don't have a caseload any longer, so this became the thing that I was working on, and so my job to support preceptors, to meet with them weekly, to really be the primary liaison between the school, the students, and the clinicians. And really from our clinician level, I think clinicians are probably likely pretty creative. They very much care about clients and families and students, and so we just came together to continuously problem solve, support each other, share ideas. So that was really, really key. That's really how we all supported one another.
Thank you. And I think the last two questions we can put together. So it's surrounding the students' clinical hours. Did you run into any issues getting the hours? Were they able to get enough hours from their college? And if so, if you ran into any issues, how did you manage to adapt to ensure they got their hours they needed?
Yeah, I mean, I can speak to on the rehab side. I think that there was a lot more trust, I guess you could say, in terms of indirect hours spent. And I think looking at the quality of the projects that were received, and I do know that people spent a lot of time on their own working on those projects. But we can't monitor them all. So I think there's a level of just trust that you have to have that people are putting in the work when they're not with you, whether it's writing a report, which can take a clinician 2 hours, but it might take a student 10 hours to write, right? So I think just the level of trust and hoping that people are kind of accountable to their time. I mean, to be honest, do I suspect that there are some students that were at a workshop virtually that were maybe kicking it at a beach somewhere, probably, right? If someone that forgets to put their mic on mute at the inopportune time, and you kind of realize where they are for sure. But I think for the most part, people were pretty responsible with their time.
Yeah, just to follow up with that, there was definitely a few laughs and squirmish moments with students not on mute, and that was, always interesting. But just like anybody else, when you can work remotely, we're all sort of multitasking and trying to make it work. For us, in our first go of the placement, we did track hours actually really carefully. We had the preceptors tracking hours, we had the students tracking hours, whether they were working on their placements or it was clinical, direct time, indirect time. And what it actually turned out to show us is that they spent way more time working clinically and indirectly in this placement than other placements. It was really surprising and surprising to the students, because you are working remotely and because there's sort of flexible hours and you're not working 9 to 5, students found themselves working in the evenings, early in the morning, on the weekends. Much like we would all experience, working from home these days a little bit more. It's kind of hard to figure out when the day starts and when it ends. And because they had these independent projects that, they really threw everything that they had into them. So we actually had in my section of the placement, it was a project for 3 or 4 of the students to kind of track all of the hours, do an evaluation and a presentation to our senior leadership on just exactly how time was spent. So it was really enlightening at the end.
Thank you. That's it for questions. Thank you.
Well, actually, I have a couple of questions. If you don't mind, Kathleen and Colin. And what you were alluding to at the beginning of your talk, Kathleen, was that how this kind of all evolved through baby steps. And many of the people who are watching maybe didn't realize initially when they were showing up to this that this wasn't just kind of your one-off virtual placement. This was an organization-wide whole class, very large volume virtual placements. But kind of take what you've learned and think about what you could say, what you could give as advice as maybe baby steps for that one-off clinician at a smaller organization, or perhaps in their own private practice. What baby steps would you recommend to someone considering offering a virtual placement at their own site?
Yeah, really good point, Mike. So, on reflection, I was able to really think about all the baby steps along the way. And the baby steps probably for me started way back when I took my first student. It probably, the year that I was able to as a new clinician. And, really just building your confidence, experience with taking students. And for me, it's always been a bit of a, it's always a bit of a stretch when, it comes that time to say, are you going to take a student? What is it going to look like? And for me, I just always said yes, because once I started saying yes, it was just an overwhelmingly positive experience. Not only, for the clients that I was serving, but for me as a clinician, sometimes you get out of school or you've been working for so long and you just think, I want to stop learning for a bit. I want to pause and, put my head down and just work. But I think we all sort of have that feeling inside that, we are continuous learners. It's important, for us as clinicians, but, as human beings as well, to continue to learn, to continue to push ourselves. And, I think students are just that right fit where they come in and, as Colin said, you get to do a bit of teaching, a bit of cross-generational learning. They motivate you. You get to share, your thoughts and experiences with them. And, that has an amplified effect to whoever they go out and serve in the community or, wherever they go in their career. And, for virtual care, I think it's even less scary. There are so many resources out there. It's a time when, we need to be careful with our human health resources. We need to optimize them, as I said, to amplify them. Students can really help us to reach more people, to build our capacity. We're helping them, go out to the world and really build stronger communities. And, back to that network piece, there's all sorts of people in your network that will help you do this. Colin and I would be happy to support you. We have a ton of resources, but there's other people, if you look around right in your closer networks that will help you offer, I think, virtual placements. And take it day by day. It doesn't need to be perfect. Students want to learn, they want to graduate, they want to help. They have amazing skills, so that would be my advice. Take the leap of faith, and I think it'll come back, tenfold.
Yeah, I mean, I would agree with all of that. I think the trepidation that a lot of therapists have, I think, on taking students in general, but definitely with the virtual placement is, one, you're going to have eyes on you, right? People are going to be looking at you, judging you, and you're out of school now, and you may not have that confidence in yourself that you're doing the right thing, or you don't want to be doing the wrong thing and teaching something that you shouldn't be to a student. But then the other feedback that we get often is they're just too busy, right? That people don't want to take students because you're going to be spending extra time talking to them afterwards and teaching them, and you're spending time that you don't have to give. But I think what we've seen is that, yes, there's going to be some time up front for sure where you're spending a bit extra. But by the end of it, by the latter half of that placement, especially if you have 2 or 3, actually, when you have 2 or if you have 5 or if you have 10, honestly, it's no extra work, not that much more work, just because if you have 10 clinicians working under you, in essence, for free, you can actually increase your reach and scope and work with more clients than you would have just doing your own work independently. So yes, there's going to be a little bit more work in the beginning, but these students, if you teach them right up front in the first few weeks, they can write reports for you. They can do all the things that you don't want to do, all the things that grind you down day to day, they can take that load off of you. So by the end of it, definitely a worthwhile experience. There's a little bit of extra work up front for sure, but I think in the end it pays off.
Yeah, and just to add to that, think about how students can work well with you. That was, the piece about this placement that was important. And every time I take a student, how will this fit in well with me? Where I'm at in my career and the projects I'm working on, where can I offer them an experience, that will both be doing work that's valuable and meaningful, and that will be useful. I think that goes a long way in a placement. And then, one other tip that I have is, if you do decide to take a student, talk to them, get to know them, figure out where their strengths are, figure out where their interests lie, and then, sort of wrap the opportunities and experiences around that. They'll be happy, you'll be happy, they'll excel, they'll be helpful. That's always just been a really sort of go-to strategy for me.
Yeah, and just for the record, after those group placements, I think we've hired probably a dozen students, if not more, that we had a kind of insight into. So it was a great resource for recruiting.
And for us in home health, I think we're like up around 46 or 47 that we've hired.
Oh, wow. Seriously. Jeez. Nice.
Yeah.
And that was actually my second question. I was wondering, with all of the data that you were collecting, I would assume that you would follow up these students after graduating to see whether they've gotten hired and whether or not this placement was considered as an asset to the people who hired them. So Kathleen, in home health, you personally hired over 40?
I think it's like 47 this week. Yeah, it's been incredible. We have, new OTs everywhere. And if you think about that, once again, back to the collaboration and the network, I know these students so well. And now they're within the organization and part of the culture that they helped create. And, you know about their skills and their strengths, and you can reach out to them. So it's just such an interesting sort of ripple effect that the placement has had, keeping these students close to CBI. And, I think just like in any placement, when you take on students, if they're a good student and there's a need, you find a way to make room for them within the organization. You find a way to bring them on or keep them close. So that's really neat. And back to the data piece, we have so much data we don't know what to do with the students, from those placements. It was just so cool. And that, also taught our clinicians and teams, we need to be collecting way more data in our everyday lives to really understand, the multiple things that are going on a daily basis that affect our health and wellness and how our organization runs. And so another key piece for us, and I didn't say it initially, was partnering with Western to make sure that we were going to be working on research throughout the placements and translating some of that data into studies and articles and focus groups that we've done post the placement. So really translating that into that research piece.
That's great. Thank you again, Kathleen and Colin. I'm glad that everything eventually came together and that we were able to have the session. And I apologize that we are a little bit over time, but definitely wanted to make sure that we were able to hear what you had to say today and have your the questions answered. And thank you both very much. Again, we truly appreciate it. And, in 2 weeks' time, we'll actually be having our final webinar of the year, and that will be on Francophone health. And the RSVP for that event will be coming out next week. So keep an eye out for that. But once again, thank you both, Kathleen and Colin, and I hope everyone has a great evening.
Great. Thanks, Mike.
Thanks so much, Mike. Thanks, Colin. I appreciate the help.
Thanks, everybody. Kathleen. Good night, everybody.